Hello everybody, welcome back to the Pediatric Masterclass. So today we'll be discussing yet another very interesting and a clinically oriented topic, which is iron overload and beta thalassemia. So we know that the mainstay of therapy for transfusion dependent thalassemics is chronic blood transfusion, and along with the blood transfusion comes with this inevitable complication, which is iron overload. So we'll be talking about the pathophysiology of iron overload. How do we diagnose it? How do we treat it? So there are iron chelators available, different types. So we'll be discussing each one in detail, advantages and disadvantages, and when to use which one. And then how do you monitor iron overload? So without wasting any further time, let's begin the discussion. So what is the mechanism of iron overload in thalassemia? Before I go into the discussion, I'd like to clarify that now the terminology used is transfusion dependent thalassemia and non-transfusion dependent thalassemia. Earlier we used to call it beta thalassemia, major, intermediate, and minor, but now the terminology has changed. So it's transfusion dependent and non-transfusion dependent. So that is what I'll be using for the rest of the presentation. So when we talk about mechanisms of iron overload, there are two major mechanisms. The first one is repeated blood transfusions. Now in the transfusion dependent thalassemics, like we've just seen in the previous discussion, that the mainstay of therapy is chronic blood transfusion, and approximately every 1 ml of pure red blood cell has about 1 milligram of iron. So that's a lot of iron that gets accumulated in these thalassemics who are transfusion dependent over time. So much so that the amount of iron that is accumulating is way more than what the body can metabolize and excrete. So that stays the most common cause of iron overload in the thalassemics. Again, mainly the transfusion dependent. But another mechanism of iron overload, which is again the most common in the non-transfusion dependent thalassemics, is excess GI absorption. So what happens is when there's anemia, the body kind of senses the fact that there is a deficiency of hemoglobin. It tries to compensate by increasing the absorption of iron from the GI tract. And that is the most common mechanism of iron overload in the non-transfusion dependent thalassemics. Having said that, in the transfusion dependent thalassemics, the most common mechanism is the chronic blood transfusions followed by excess GI absorption, because again, if they are left under transfused, the body is again able to sense the fact that there is anemia and I need to compensate by increasing the iron absorption. So to summarize, two basic mechanisms of iron overload remain repeated blood transfusions and excess absorption from the GI tract. So we know that iron overload is detrimental. So what are the effects of iron overload? So if you look at this diagram from the NEJM, there are certain organs of the body that have a high predisposition to iron overload as compared to the others. So the liver, heart, and the endocrine organs are the most commonly affected ones. So chronic iron overload can lead to liver cirrhosis, it can lead to heart failure, it can lead to endocrinopathies and growth retardation. So what is the rate of accumulation of iron? Now there are again two important concepts to consider. The first one is the transfusion dependent thalassemics, where about 1 ml of pure red blood cell transfusion leads to accumulation of about 1 milligram of iron. And if you look at the recommended transfusion schedule in these patients, they receive about 100 to 200 ml per kg of pure red blood cell over a year, which leads to approximately about 0.3 to zero point 0.6 milligram per kg per day of iron accumulation in these patients. The other mechanism that we saw was the excess GI absorption. So normally, in normal individuals, the daily iron absorption is about 1 to 2 grams per day. 1 to 2 milligrams per day, I'm sorry. But especially in those who are under transfused or have low hemoglobin, the body tries to compensate by increasing the iron absorption to as much as 3 to 5 milligrams per day. Okay, so we do know that it is recommended to keep the pre-transfusion hemoglobin above 9. Now, where does this number 9 gram per deciliter come from? So there was a study conducted in 1997 by Cazzola et al., where they studied the different levels of hemoglobin and its association with the iron overload, and they were able to come to a conclusion that if the pre-transfusion hemoglobin is maintained above 9 grams per deciliter, It prevents iron overload by inhibiting the bone marrow expansion. So that's why we should aim to keep the pre-transfusion hemoglobin above 9 gram per deciliter. So, what is the mechanism of iron toxicity? So, irrespective of whether the iron overload is because of increased intestinal absorption or whether it's because of frequent blood transfusions, both of these lead to increased transferrin saturation. So, normally the iron that enters the body binds to transferrin and is then transported to the different organs where it is utilized for different purposes. But what happens when the amount of iron is in excess? It leads to supersaturation or hypersaturation of transferrin. So when the transferrin saturation exceeds 70%, it leads to the formation of the NTBI, that's the non-transferrin bound ion, and the labile plasma ion. So basically, in simple words, this is like free iron. Now, free iron leads to formation of reactive oxygen species, which leads to mitochondrial damage, lipid peroxidation, DNA damage, protein denaturation, and the destruction of lysozymes. So, with all of these mechanisms, iron overload leads to organelle damage, and like we saw, it predominantly affects the heart, liver, pancreas, and the other endocrine organs. So, if you look at the mechanism of iron toxicity, it can lead to neoplasms, infections, apoptotic cell death, and fibrosis. So another interesting question as to why is it that there are certain organs in the body that are affected by iron overload more than the others. Like I've said it multiple times that iron overload predominantly affects the liver, heart, and the endocrine organs. Now, why is it that these organs are affected more than the others? So what happens is normally iron uptake by the cells is determined by the interaction of transferrin with its receptors because the iron is bound to the transferrin. So these uh, interactions are predominantly seen on the RBCs, hepatocytes, and the dividing cells because these are the ones that use iron the most. But in iron overload, when you have the non-transferrin bound iron or the free labile iron, the organ damage depends on how much iron the tissue is taking up, which again is dependent on the presence of certain calcium channels. Okay, so some tissues get spared like the skeletal muscles, so you don't really see iron overload affecting the skeletal muscles so much, but the myocardial muscles, the hepatocytes, the endocrine tissues are the ones that rapidly pick up the non-transfusion bound or free iron, and that's the reason why these are the organs. So the liver, the heart, and the endocrine organs are the ones that are affected the most because of iron overload. And then once iron enters these organs, it is stored as ferritin or hemosiderin, which we are then able to measure or visualize on imaging as markers of iron overload. So we've talked about mechanism, pathophysiology, and how iron overload causes damage. So the next question or the next important practical question would be, how do you monitor for the presence of iron overload? So the first one is that everybody knows and is the one is most commonly done is serum ferritin. And the other investigation is liver iron concentration or LIC. Now let's look at both of this in detail. So the first one is serum ferritin, which is the easiest, the cheapest method and non-invasive method of estimating iron overload in the body. Rather than looking at one single value of serum ferritin, it's always better to monitor trends to see whether the ferritin is in the same range. Is it increasing? Is it getting better with time and with treatment? So basically, trends are more important than a single value. And studies have shown an association between the serum ferritin and the prognostic benefits. So the serum ferritin is well controlled or well within normal limits. It has a better prognostic impact on the patient versus somebody who has severe iron overload and has very high levels of serum ferritin. However, there are certain limitations with this investigation. The first one being serum ferritin is an acute phase reactant. So, like other ARPs like CRP or ESR, for example, all of these are acute phase reactants. So, the values of ferritin can increase in the presence of infection or inflammation. So when you have a high ferritin value, there could be various or multiple reasons for that. And that's why that is one of the common limitations of using serum ferritin. And second, the liver iron impacts serum ferritin. So your Kupffer cells and hepatocytes also have an impact on the amount of ferritin that's measurable in the plasma. So what happens, or what do you think when there is a sudden increase in the serum ferritin? Okay, so if you're monitoring your patient for serial values of serum ferritin, and suddenly you see that over the past 3 months the serum ferritin has shot up. So what do you think of? So it could either be because of ongoing hepatitis, inflammation, or like we just saw, infection is something that has to be ruled out before diagnosing iron overload in these patients. So we discussed serum ferritin as the cheapest and the easiest method of estimation of iron overload. Let's look at the other more reliable method, which is the liver iron concentration. Now there are three methods of estimating LIC. You can either do it by a liver biopsy, the other one is called the SQUID, and the third one is the T2 star MRI. Now, liver biopsy is still considered the gold standard, but because it's an invasive procedure, and obviously no invasive procedure is free of its complications or risks, and that's the reason why that's not the first preferred method of estimating liver iron concentration, because we have other better non-invasive methods available now. The other one that I just mentioned is SQUID. Now, SQUID stands for Superconducting Quantum Interference Device. Now, this is a very complicated high-fundu technique, which is again used for estimation of liver iron concentration using helium, but it is not very environmental friendly, and it is not some technique which is very commonly used, so we're not going to be discussing that. What I want to stress on is the use of MRI with the T2 star to estimate liver iron concentration, which has kind of revolutionized estimating iron overload in these patients who are chronic transfusion dependent. Okay, so let's now talk about the use of the T2 star MRI for estimation of iron overload. So, in simple terms, different organs in the body have different magnetic properties, and this phenomenon is used by this technology to be able to identify iron overload. So, when I talk about T2 star, it refers to the relaxation time, which is again different for different uh, organs, and the more the amount of iron in the body, the lesser will be the T2 star value. Okay, so if you look at this image on the top, this is a liver with normal iron levels. So we see a nice homogeneous texture of the liver, which appears around grayish in color. And the T2 star value estimated on MRI is 15.7 milliseconds, which corresponds to a liver iron concentration of 1.9 mg per gram of dry weight of the liver. Whereas if you look at the image on at the bottom, if you look at the texture of the liver, it appears more heterogeneous and blackish in color. And if you look at the T2 star value, it's 1.1 milliseconds, corresponding to a liver iron concentration of as high as 29 mg per gram of the liver dry weight. So if we just look at the numbers, the lesser the T2 star, more is the liver iron concentration. Similarly, if you look here, the T2 star is 1.1, which corresponds to a liver iron concentration, which is way higher as compared to this. So one thing to remember is that the T2 star is inversely proportional to the amount of iron overload, or in simple language, more the iron overload, lesser is going to be the T2 star value. So what is the normal liver iron concentration? So the normal LIC is up to 1.8 milligrams of iron per dry weight of the liver. When the LIC crosses 7, it refers to as moderate iron overload. And when the liver iron concentration is more than 15 mg per gram dry weight, it refers to severe iron overload, which has a strong association with hepatic fibrosis. And this liver iron concentration can also be used to calculate the total amount of iron in the body with this formula. So the same concept that we just discussed also applies to the myocardial iron overload. So again, if you look at the top image here, uh, the myocardium, which is this dark gray area that we can see. over here. The top column refer is a normal myocardium with a T2 star of 22.8 milliseconds with a myocardial line concentration of around 1 mg per gram. Whereas if you look at the image at the bottom, the myocardium looks more black in color, which is abnormal, and the T2 star value is lower, which again refers to or corresponds to a higher amount of myocardial ion concentration. So after liver, the next organ to be affected because of iron overload is the heart, and we can evaluate the presence of iron overload in the myocardium either with the help of a T2 star MRI of the heart, and also another method is estimating cardiac function using a 2D echocardiography. After the liver and the heart, the other organs affected by iron overload are the endocrine organs. So the pituitary gland leads to hypothyroidism, and hypogonadotropic hypogonadism, which leads to growth retardation and delayed puberty. You can have hypoparathyroidism, insulin dependent diabetes mellitus, and growth retardation. So that's why estimation or evaluation of the endocrine functions with time in those who are chronically blood transfused is also very important to evaluate the presence of endocrinopathies, and if diagnosed, they need to be treated within the right amount of time. Now we've seen the mechanism, pathophysiology, and the effects of iron overload. Now, how do you actually treat iron overload? So the treatment is with the help of iron chelation. Now, what is the principle of iron chelation? It basically aims at increasing the excretion of iron from the body, either in the urine or the feces. But then, what are the challenges that we can face or we will probably face while treating iron overload? The number one challenge is to have a perfect balance between over and under chelation. So, you don't want to over chelate your patient to cause iron deficiency, and at the same time, you don't want to under chelate so that he has excess iron overload. So to maintain or to strike a perfect balance so that the iron concentration is adequate is a difficult task. Second is the compliance of the patient with the iron chelation. Okay, so once started, the patient has to be regular, compliant, diligent with the medications. They have to come for regular follow-up. Certain blood investigations and other imaging techniques have to be done to see what is happening with the iron content in the body. And that is why these are the two common uh, clinical challenges that we face while treating these patients for the presence of iron overload. So let's now discuss what are the types of iron chelations available. So you can have preventive, rescue, and emergency. Now, as the name suggests, preventive is to prevent iron overload, which is definitely the preferred and the best type of iron chelation. The next one is rescue. So once iron overload has occurred, you try to increase the excretion as compared to the accumulation of iron to get rid of the extra iron from the body. The third one is called the emergency iron chelation, which is when you have end organ damage where urgent action is required. Like, for example, the patient is in heart failure because of the excess iron overload. That is when emergency iron chelation comes into picture. And obviously, as the name suggests, the best is preventive, and we should try as much as we can to never reach to the phase of emergency iron chelation. Now, why is it so difficult to strike that perfect balance to be able to manage ion chelation? But that is because ion chelators only interact with the labile ion pool and not with the ion which is stored as ferritin or hemosiderin. Now, the labile ion or the non-transfusion or non-transferrin bound ion is constantly being generated, and that is the reason why chelation is going to be efficient only if the chelator is continuously available so that the labile ion which is continuously being generated by the body is taken care of. And that is why compliance with ion chelation is very important to be able to achieve the target that you want to with the dosages and the options of ion chelators that you are using. So when do we start ion chelators in these patients? So once the serum ferritin crosses 1000 nanogram per ml, is when iron chelators need to be introduced, and this roughly corresponds to after about 10 to 20 transfusions of blood. So that's why it's very important to monitor the serum ferritin values regularly, because the moment the levels cross 1000 is the time when iron chelators need to be introduced. Now, there are three iron chelators that have been approved and are being widely used for treating iron overload. It's very important to know the names, the mode of administration, the dosages, the associated side effects, and how do we monitor for these complications. So we look at each one in detail, but the names of those three iron chelators are deferoxamine, deferriprone, and deferacetox. Now let's look at the broad differences between the three iron chelators. First, we'll talk about deferoxamine. So that was the first developed iron chelator and is licensed worldwide as the first line agent. However, it is supposed to be given over as a subcutaneous continuous infusion over 8 to 12 hours, at least 4 days a week. So this is the disadvantage of deferoxamine, that it is not feasible because it's not an oral preparation. It has to be given as a continuous subcutaneous infusion. It can also be given as an IV infusion, but it has to be subcutaneous because the half-life is very small. The dosage is about 20 to 40 mg per kg per day, and it is said that while giving deferoxamine, we should also give vitamin C because it increases the excretion of iron from the body. So that's about deferoxamine. If we talk about deferriprone, also known as Kelfer, that is the second line oral iron chelator that's used in kids more than 6 years of age. It's an oral preparation. It needs to be given in TDS doses. So the dose is 75 to 100 mg per kg per day, but it has to be divided in 3 doses. The third and the most commonly used iron chelator is deferacetox, the one that we commonly know as Deserox, which is the first line oral agent used in kids more than 2 years. It's an oral preparation. It comes in two different forms. It can either be a disposable tablet, which is given at a dose of 20 to 40 mg per kg per day, or another preparation available is the film coated tablet, which is a different dose of about 15 to 28 mg per kg per day. What is available in the country and what is frequently and most commonly used as a disposable tablet. So we'll be discussing that in detail. But it's just important to know that there are two different preparations available, and the cost is different, the dosage is different, and the method of consumption is also different for both of them. So we saw that deferoxamine is the first line agent and was the first ever used iron chelator, but the disadvantage is that it has to be given as a continuous subcutaneous infusion. However, having said that, it is extremely effective in severe iron overload. So for your rescue and emergency therapies, deferoxamine is commonly used. It can also be given as a continuous IV infusion. However, the common side effects of using deferoxamine are a local reaction, hearing difficulty or sensorineural hearing loss, ototoxicity, retinal toxicity, skeletal abnormalities, and infections with Yersinia and mucormycosis. So now we know the side effects of using deferoxamine. So how do we monitor for these side effects? So with respect to audiology, a baseline audiogram is a must before starting the medication. And then every time they come for repeated transfusions, a screening hearing test should be done every 6 months. A formal audiogram is a must yearly. And every time they come for transfusion, you should always ask them for any hearing complaints, any tinnitus, any ringing in the ears, or decreased hearing, etc. So any new symptom that they develop with respect to the hearing should always be evaluated. Deferoxamine is also known to cause retinal toxicity, and that's why a formal evaluation by the ophthalmologist is required every 6 months in kids and yearly in adults, because the kids might not be able to tell you that they're facing or they're experiencing any visual complaints, and that's why having formal evaluations more frequently in kids makes more sense. And always ask for visual acuity, field, and color vision every time they come for their transfusions. LFTs and RFTs need to be measured or monitored every 3 monthly. And if there are any elevations in the liver enzymes or there's an increase in the urine protein or serum creatinine, that warrants for adjustment of the dose. Interestingly, deferoxamine is known to cause skeletal side effects, so growth velocity is very important to be monitored for those who are requiring chronic deferoxamine infusions. So sitting height as compared to the total height needs to be taken every 6 monthly to detect early spinal growth defect. Now, what do I mean when I say? So this is what sitting height looks like, and this is how it is monitored. So the patient is made to sit, and this height is measured, and this is then compared with the actual standing height. Because deferoxamine is known to cause effects or have complications on the spinal growth and spinal fusion, that's why sitting height recording is very important for those who are requiring DFO infusions. The next iron chelator is deferriprone, also called as Kelfer, which is an oral iron chelator given at 75 to 100 mg per kg per day in 3 divided doses. Common side effects include neutropenia and agranulocytosis, GI discomfort, elevated liver enzymes, and arthralgia. So, how do we monitor for deferriprone side effects? Most importantly is hematological because it causes agranulocytosis and neutropenia. So ANC or absolute neutrophil count should be monitored ideally weekly for the first 6 months, then every 2 weeks for the next 6 months, and then every monthly for about a year. If at any point of time the ANC falls below 1500 cells per microliter, that warrants for stopping Kelfer, and those patients who have fever should immediately be assessed for the absolute neutrophil count to see if they have agranulocytosis or neutropenia, because it is a common complication of using deferriprone. So fever in some patient who is on Kelfer should not be just ignored, and ANC is a must for these patients who have or who ever develop fever. The next is arthropathy. So if the patient ever complains of joint pain, arthralgia, it warrants for stopping the drug. And then when it needs to be restarted, you have to restart it at a lower dose as compared to what the patient was already receiving. Liver function test again every monthly, and depending on the liver enzymes, the dose needs to be adjusted. Interestingly, those usually adults or older kids who have diabetes have associated zinc deficiency. So measuring zinc serum zinc levels in those who have diabetes and growth retardation is something that should be thought of. And if the zinc levels are low, then we need to start with zinc supplementation. The third and the most common and interesting iron chelator that is used widely is deferoxamides, also called as Deserox. So it's the most widely used iron chelator. The preparation that's available in the country is the dispersible tablet. The dosage given is 20 to 40 mg per kg per day. It has to be given as a single dose, but there are certain instructions that need to be given to your patient when you start them on Deserox so that the medication works and you're able to achieve your target of controlling iron overload. So, certain instructions that you need to give to your patient when you start Deserox is that first it needs to be taken once a day. It has to be taken on an empty stomach or at least 30 minutes before a meal. Now, the next interesting thing is how do you take Deserox? So, it's not supposed to be chewed or swallowed as a whole, like normally tablets are or capsules are swallowed with water, but that is not how Deserox is supposed to be taken. Since it's a dispersible tablet, the tablet needs to be dispersed in a glass of water, or they can use apple or orange juice. I know it's a little expensive to dissolve your tablet in orange juice every day, so water is another cheap option, but it's effective. So the tablet needs to be dispersed in about 100 to 200 ml of water. It needs to be taken in a glass container, not in a steel container, because when dissolved or when dispersed in a steel container, it tends to stick to the boundaries of the glass. So preferably it has to be done in a plastic or a glass container. 100 to 200 ml of water needs to be taken. The tablet needs to be added, and they need to make like a solution out of that. So by stirring it, the tablet is dispersed in the liquid, and then they're supposed to consume that entire liquid that is prepared. So that is how Desirox needs to be taken. So these instructions are very important for you to give to the patient or the parents, depending on the age and who the caretaker is, because to ensure that your Desirox is working well at the dose that you have prescribed, this method is extremely important. And every time they come to you for a follow-up, ideally you should ask them how they're taking Desirox, so you know the compliance and you know if they're actually following the instructions or not. So common side effects of Desirox are GI discomfort, renal and hepatic toxicity. So liver and kidney function needs to be monitored regularly, and at the same time, the dose needs to be adjusted if there is an elevation of either the liver enzymes or the renal parameters. CBC needs to be done baseline and then ideally every monthly, because Deserox can cause neutropenia, agranulocytosis, anemia, and thrombocytopenia. And yes, auditory and ophthalmic evaluation is also important and needs to be done yearly. Another interesting concept is what is called the combination therapy. Now, as the name suggests, it means that different combinations of iron chelators are used for the purpose of treating iron overload. It helps in improving efficacy by something called as the shuttle mechanism or the shuttle hypothesis. Now, what does this mean? Is that different iron chelators work by different mechanisms and helps in increasing the efficacy of excretion of iron from the body. So like if you're using two different iron chelators, one helps in mobilizing iron from the tissues and the other helps in excretion of that iron from the bloodstream. So both the ions both the chelators act synergistically with different mechanisms to increase the efficacy of excretion of iron from the body. So that is the concept of combination therapy. Obviously, the application of this comes in where one iron chelator is not good enough to maintain your iron levels, or if the patient is having complications or side effects with the prescribed dose of the iron chelator that you're giving, so that you're not able to give a higher dose, and that's where the addition of another iron chelator comes into picture. So these are the indications of where you might have to use a combination therapy, and different combinations can be used. So you can use Deserox with Kelfer, you can use deferoxamine with deferoprone, depending on the indications, the level of iron, and whether you're using the iron chelators for rescue, emergency, or like urgent application, or those things. So certain things to be considered before deciding what combination of iron chelators you would want to use and what dosages you would want to apply for it. One last thing, how do you monitor for iron overload? So like we saw with the diagnosis, we can use serum ferritin, the liver iron concentration, and the myocardial iron concentration. So serum ferritin ideally needs to be done every 3 months. You need to maintain a target of around 500 to 1000 nanogram per ml, and it's always important to monitor trends of serum ferritin rather than one absolute value. So you need to see if the ferritin is falling, it's increasing, it's staying in the same range, and accordingly your decision of titrating the doses of iron chelators is going to play an important role here. The second one is your liver iron concentration. So when you have the LIC, like I said, LIC stands for liver iron concentration. If it is stable in the range of 3 to 7 mg of iron per gram of dry weight of the liver, Then your T2 star MRI for estimation of LIC needs to be done every 1 to 2 yearly. But if the levels of LIC exceed 7, that means there is more iron overload, and then you need to do your T2 star MRI every year. Okay, so this is the difference as to how you would decide how frequently you would like to do certain investigations depending on what your reports are. Myocardial iron overload, so a stable T2 star of more than 20 milliseconds. So then in that case, your MRI needs to be done 2 yearly. So like we saw in the previous slides, higher the T2 star, lesser is the iron overload. So if the T2 star is more than 20, you need to do it 2 yearly. If the T2 star is between 10 to 20, needs to be done yearly. And the T2 star value of less than 10, that means there is significant amount of iron overload. In those conditions, you might have to do your T2 star of the heart every 6 months to see whether there's an increase in the iron overload, whether your iron chelation is working, or if there are any extra steps that you might have to do to prevent reaching a condition where you might have to give urgent iron chelation in place where you have end organ damage. So that concludes our discussion on iron chelation in transfusion dependent thalassemia. References for this topic basically mainly include the 2021 latest guidelines of Thalassemia International Federation, the TIF guidelines for the management of transfusion dependent thalassemia. I've also attached the link here if you guys want to have a look. It's an extensive PDF with all the guidelines, but I have only spoken about iron overload and iron chelation in this topic. And the second reference is definitely up to date. So thank you so much everybody for watching the video. I hope this discussion was informative and it has helped you. If you like the video, please like, share and subscribe. You can also leave your comments. You can also write down any questions that you have related to the topic, or even other topics that you would like me to discuss in the future discussions. So thank you once again for watching the video.